here the criteria for evidence of hypoperfusion from the shark group definition. So either you have one or more of the following. The first one is elevated arterial lactate of 2 millimole or more. The second one with acute kidney injury, which is defined by creatinine, which is equal or more than twice the upper limit of normal. Or there is oliguria or decreased urine output of less than 0.5 ml per kg per hour. The third criteria is the acute hepatic injury, which is defined by the increase in ALT by 3 times or more of the upper limit of normal. The fourth criteria is the caul or mottled extremities. The fifth criteria is the altered mental status, which is not explained by other causes, namely like septic shock or hypovolemic shock or other causes of altered mental status. And here they added the hemodynamic criteria, which is optional in case that you have invasive hemodynamics monitoring. So, which is basically the usual definition for cardiogenic shock. The cardiac index is less than 2.2, or the SVR is more than 2,200. Now, the problem with the historic definition of cardiogenic shock is that it mainly focuses on or limit the definition or include the definition of systemic hypotension, which is problematic actually, given that there are a number of cases, around 5% of cardiogenic shock, they can have normal blood pressure. And according to the SHARC recommendation, we define those group as normotensive cardiogenic shock subtype, where they have systolic blood pressure more than 90 without any support. But there is evidence of hypoperfusion, one of the criteria that we just mentioned. And the other criteria is that the other causes of shock must have been excluded. And here again, just showing why it's important to recognize these type of shock, because it's most of the time it's missed due to the preserved blood pressure. The other things is it has almost the same mortality as the classic or full-blown cardiogenic shock. Here is just a figure from the cardiogenic shock working group registry. It's just showing the etiology of cardiogenic shock and the mortality rate. So if you can look up, if you see here in figure A, the heart failure was representing around 52% of cases, while MI-related cardiogenic shock represent around 32%. And the rest, which represent around 16%, is non-heart failure, non-MI-related cardiogenic shock. In figure P here, it just showed the mortality based on the etiology. So the heart failure-related cardiogenic shock has a mortality of 25%, while the MI cardiogenic shock has almost like 42% mortality rate. And overall, the mortality is 35%. The figure or part C here just showing that the out-of-hospital cardiac arrest, it just add additional mortality rate across all type of the cardiogenic shock. And here's the SKY stage classification of cardiogenic shock that was endorsed by the ACC 2025 writing committee. And this basically was just like and adopted by the KBER and its group. And what's nice about this things, when compared to the old definition, it does incorporate or include the clinical and lab parameters to diagnose the cardiogenic shock. So if you look up here in stage 1, this is patient at rest who haven't had either signs of hypoperfusion or hemodynamic instability. You go to stage P, where there is evidence of either hemodynamic or hypoperfusion instability. And you can see that at this stage, they start showing some organ damage manifested here by like minimal kidney injury. And they could have like systemic manifestation of hemodynamic instability. And once you go on to stage C, this is the at which you can see the main feature of cardiogenic shock, which require either support, pharmacological or mechanical support beyond the volume resuscitation. And going through part D, in which there is a failure of the support to restore perfusion, and ending up on stage E, which there is association with impending circulatory collapse or multi-organ failure. And this is the data from the Critical Care Cardiology Trial Network Registry, and it just shows you how powerful and how important is the SCAI stage classification. So if you look up here onto the mortality, it showed that there is a stepwise increase in mortality as you go up from each stage to the next. And you notice here that a sharp increase in mortality rate, for example, here from stage P 2.2 into stage C 15.8%. And it just emphasized that the early recognition of shock and early intervention is critical for the early stage of cardiogenic shock. So what is the role of invasive hemodynamics in cardiogenic shock? It just basically helps the physician to characterize the cardiogenic shock phenotype, assess the severity, and guide the route to mechanical support. Now, there are no big or like large RCT, prospective RCT that showed improved mortality with these and outcome with the PA catheter, but observational data from different registries show that the early introduction of PA catheter, especially within 12 hours, is linked to lower in-hospital mortality. The previous ESCAPE trial, which was done to assess the PAC catheter in heart failure patient, actually excluded the cardiogenic shock or the typical cardiogenic shock patient, because this trial didn't show any mortality benefit, but we cannot apply this trial to cardiogenic shock patients. There is the ongoing trial called BACS trial, which the Toronto General Hospital, I think, is part of it, which is going to assess whether early PA catheter introduction is going to help improve survival in heart failure-related cardiogenic shock. So here's the typical congestion profile in cardiogenic shock, as we know. So the LV dominant, as we know, they have like elevated left-sided pressures manifested by elevated wedge pressure more than 15. And the RV dominant, congestion or cardiogenic shock, they do have isolated elevated right atrial pressure, which is manifested by the atrial or right atrial pressure more than 15. And of course, if you have biventricular congestions or biventricular cardiogenic shock, you would have the mixture of both, elevated pressure on both sides. For both biventricular and RV dominant profiles, they both are associated with worse outcome, including death, the LFAD or ventricular assist device need and heart transplantation. Just like this is an AI-generated heart failure profile, which just illustrated the heart failure profile. And what we're interested here, or our talk is mainly going to be in this part, in which you have like the hypoperfusion, so either cold and dry or cold and wet. There are certain parameters which are important in invasive hemodynamics and has been associated with worse outcome. One of these is the pulmonary artery pulsatility index, or PAPI, which is basically defined as the pulmonary artery systolic pressure minus the pulmonary artery diastolic pressure divided by the right atrial pressure. And it's most reliable when the right atrial pressure more than 10. And of course, there is no severe pulmonary hypertension. And what's important about this, and if you have the value in less than 0.9 in presence of MI, this tells you that it's suggestive of RV failure and it's been associated with worse outcome. Also, in view of MI, if the value is less than, and in LFAD candidate, if the number is less than 1.85, it just suggests the RV failure and worse outcome. So here there are other parameters that's been associated with worse mortality. So if you have MAP, you have elevated right atrial pressure. If the ratio of right atrial pressure to wedge pressure is more than 6, and as we mentioned, the low pulmonary artery pulsatility index. What's the role of shock team management in cardiogenic shock? This is a nice study that was done based on the critical care cardiology trial network in the US, and it involved multiple centers across the US. And what's been done basically in this study is they randomized the cardiogenic shock across these centers into the centers where they do have the shock team versus the centers in which they don't have a shock team. The shock team is defined by presence of critical cardiologists, advanced heart failure specialists, interventional cardiologist, cardiac surgery, and ECMO service. And if you look up to this part, the dark blue part, or PAR, which represents the outcome in centers where they do have the shock team. So those centers with a shock team have a higher use, of course, of PAC, or pulmonary artery catheter, 60% versus 49. Those shock team centers, they had overall less use of mechanical circulatory support, but advanced mechanical circulatory support was more on the shock team centers. And I think the most important thing is, as you notice here, the mortality in CICU, where you do have the shock team, is lower than those who do not have a shock team in their center. So the message of this is just shock teams improve outcome, reduce mortality in cardiogenic shock, and it enabled the faster use of invasive monitoring and advanced mechanical circulatory support. Okay, so before we move to the next part, here's the clinical takeaways from the initial diagnosis and evaluation. Number 1, hypoperfusion and not hypotension alone defines the cardiogenic shock. Blood pressure can be misleading. Always look for signs of poor organ hypoperfusion. Normotensive cardiogenic shock is a common and deadly if missed. 55% of patients, they have a normal blood pressure, but still have higher mortality if hypoperfusion is present. The third one is the pulmonary artery pulsatility index, help the assess the right ventricular function, and also has been associated with mortality if the value is low. The multidisciplinary team and the shock team improve survival. by enabling early coordinated intervention and overall reduction in mortality. Okay, moving forward. So what kind of pharmacological support do we have in cardiogenic shock? This slide just to summarize the different type of vasoactive agent and their mechanism of action. I'm not going to go through them. So the question is, what kind of drug should I use in cardiogenic shock? So the DOREMI trial is a clinical double-blinded randomized trial that was done on Ottawa Heart Institute that included like 192 patients with the different cardiogenic shock stages, ranging from SCAI stage B to E. And the group were randomized to two groups, either receiving milrinone or receiving dobutamine. Their primary outcome was the composite of in-hospital death, cardiac arrest, transplant, or mechanical support, as well as non-vital MI, stroke, TIA, or initiation of renal replacement therapy. And as you can see here, these figures illustrated the primary outcome results in both groups. So the part A here showed that there is no mortality benefit between the milrinone versus dobutamine in cardiogenic shock at 30 days. The second part, which showed the unhospital death from any cause, again, showing the same finding. There is no statistical significant difference between the milrinone versus dobutamine group. And here's the other clinical and hemodynamic measures that was done also or studied in this trial. So if you look up into vasoactive, for example, inotropic score, which basically reflect how much pharmacological support does each patient need, it's almost the same, and the lines overlap in both groups. And same here in terms of creatinine or AKI and the urine output, as well as the lactate level. So in the nutshell of this is the milrinone and dobutamine in cardiogenic shock have the same result with no superiority over each other. SOAP trial or SOAP2 trial is another trial that compared dopamine versus norepi in all kind of shock. It was done in 3 countries, and it's involved a larger number of patients, like 1,679. And again, the primary outcome was 28-day mortality. And if this figure just showing that the cardiogenic shock subgroup, they have better outcome with norepinephrine. Those patients with the dopamine group, they have a higher mortality, which was attributed to higher event of arrhythmia or arrhythmia-related death. So the conclusion was that the norepi was preferred over dopamine and has a lower mortality in cardiogenic shock subgroup. Here is another Cochrane review, just like a review that included the 19 RCT, all of them, which are like, most of them, there are a small number in size, but the point of this is that this review included a different type of inotropic agent. And the main conclusion was that none of these inotropic agents has consistently shown a reduction on mortality. The other message is that even if you see like hemodynamic improvement, this does not mean or equal mortality benefit. And up until now, there is no like universal recommended inotropic agent that we should use in cardiogenic shock. Okay, now we know that there is no strong evidence behind or suggesting the typical or particular inotropic agent use, but there is some pathophysiological based approach in how to use the inotropes and vasopressor. And this is a review article from the European Society of Cardiology. And I just want to say that both the European Society of Cardiology as well as the ACC 2025 concise clinical guidance writing committee, both are recommending the nor-epi in cardiogenic shock as a first line. Now, again, this is not based on evidence-based, but just an expert opinion if there is profound hypotension. The other recommendation that was made in this review is based on pathophysiological background. Those patients with AMI-related cardiogenic shock, they tend to have a lower SVR and higher cardiac index in very early presentation. And that explains in part why the cardiogenic shock following the MI, they usually, but not always, come with hypotension. And this is mainly driven by the inflammatory mediators, namely like the interleukin, the TNF-alpha, nitric oxide, which is triggered and released in the context of myocardial infarction. This is in contrast to a cardiogenic shock patient in heart failure related cardiogenic shock, in which those patients, they tend to have a chronic course in which they have up-regulated receptors of angiotensin 2, endothelin 1, and norepi, and that's in part explain why I'm saying most, but not all, the heart failure-related cardiogenic shock present with early like preserved blood pressure. And based on this recommendation, so if there is hypotension, the recommendation goes with norepi. If there is preserved blood pressure and evidence of hypoperfusion, then either dobutamine or milrinone would be the next or the best option. Okay, here is some steps in managing acute RV failure. So optimizing both preload and afterload in acute RV failure is very important, but at the same time, it's tricky. Now, the old or the classical teaching of that the RV failure or RV-related MI, they're preload dependent is not always correct. Of course, they're most of the time they're preload dependent, but you have to be careful and balance the overfilling and underfilling, which could affect the outcome. So in this figure, as you can see, if there is overfilling of the RV in the setting of acute RV failure, that could impact the cardiac output by causing the interventricular septum shaft to the left, compromising the LV filling diastolic pressure and reducing the LV output and further causing hypotension. Again, at the same time, the underfilling, it will worsen the outcome as well. Insufficient preload lead to reduced stroke volume and worsened cardiac output. So what is the best approach in this case? So the best approach, as suggested by the writing committee, is you try a small volume of boluses and you see your response, and you will base your clinical response based on two things. Number one, gonna check the CVB. If there is increase in CVB, like from 2 to 5, with STEL, like the CVB less than 20, and at the same time, you see an improvement in systemic perfusion, either by improving the cardiac output numbers or improving the MAP, or clinical signs like improving urine output, improving the renal profile or liver profile, or improving in mental status. That tells you there is a good response, and you could further either give a fluid or stop there if there is a response based on the hemodynamics. And if you have a negative response, that would be manifested by just increasing the CVB without the improvement in clinical parameters or systemic perfusion, that tells you that there is a risk of harmful RV distension that would further worsen the cardiac output and the hemodynamics. Just a summary here, how would you interpret the CVB in acute RV failure? So again, if you have low CVB less than 10, the hypotension, likely underfilled RV, you give a cautious fluid boluses and you reassess based on both CVB and based on the systemic perfusion parameters. If you have elevated the CVB more than 12 or 15 without systemic perfusion, then you should be concerned about overfilled RV, worsening RV dilation, and ischemia as well. And then at that stage, you may consider stopping the fluid, consider diuretics if there is a congestion. The other parameters that we can use here is the CVB ratio over pulmonary capillary wedge pressure. So if you have a ratio of more than 0.8, then that suggests the predominant RV dysfunction versus LV. And again, you would just tailor your management toward more the RV failure. Couple of things to consider also on afterload. So afterload is important as optimizing preload and RV failure. So try to minimize pulmonary vascular resistance by correcting hypoxia. Hypoxia usually causes pulmonary vasoconstriction, worsen the afterload, which will impact the RV failure. And also, as we're gonna see, the excessive PEEP decreases or increases the RV load, which eventually will decrease the RV output and worsen the shock. The milrinone, of course, is favored in these patients, and it's just because it acts both on the pulmonary vasculature and at the same time work on the RV failure. But just be cautious whenever there is hypotension. You should not consider this option, or you could consider milrinone in addition to norepi just to balance the effect of hypotension. The other caution about milrinone is if there is renal impairment, then the excretion of the milrinone will be impaired because it's a renally excreted drug. And if there is a concomitant LV failure, then just knowing that reducing LV afterload by using vasodilator or pump may indirectly help the RV by lowering the pulmonary pressures, as we're going to see in a minute. Okay, before we move to the mechanical support, here's a takeaway from pharmacological support. Number one, inotropes improve hemodynamics, but no mortality benefits. Two, milrinone and dobutamine have a comparable outcome according to DUREMI trial. RV failure volume management requires a delicate balance. Be cautious about fluid bolus and if there is underfilled, and stop fluid or diuresis of overfilled, and minimizing the afterload by minimizing the pulmonary vascular resistance is also crucial in acute RV failure. In addition to correcting hypoxia and avoiding excessive PEEP. Okay, moving to the next topic. This is a nice table that summarizes the type of mechanical support that we usually use in cardiogenic shock. So on the left side here is the RV ventricular or right ventricular support, which include the Impella RP and the percutaneous ventricular assist device. The maximum flow for the Impella RP is ranging from 3 to 4 liters per minute, while the LVAD is 4 to 5. And both the mechanism of action, both the mechanism of action just basically help to do a continuous flow from the RA to pulmonary artery, bypassing the right ventricle. And in regard to VA ECMO, this is considered like a biventricular support. For the ALFI, we have the Palom Pump, the Impella CP, and the Impella C5. And here is a bit of slide showing what's the mechanism of action of intra-aortic pump. So the intra-aortic pump simply, it does deflate in systole and inflate during diastole. And by deflating in systole, it creates a vacuum effect, and that will result in decreased LV after load, wall stress, improving output, and decreasing oxygen demand as well. By inflating during diastole, that will help in increasing the coronary perfusion pressure. So as you can see, the coronary perfusion pressure is just the difference between the aortic diastolic pressure minus the LVEDB. And by increasing the aortic diastolic pressure during the inflation, during the diastole, that will help increasing the coronary perfusion. The other point that I would just mention here, it doesn't provide a lot of flow or support. It just ranging from 0.5 to 1 liter in case of shock. The Impella device, by its different size and different sizes, it just has the same mechanism of action. So it just basically draw blood from the LV to the ascending aorta or IVC to the pulmonary artery in case of right-sided Impella support, and it provides a continuous forward flow independent of the native heart rhythm. And the result of this is just like unload the LV or the RV, reduces the pressures, wall stress, and improve the oxygen demand. Okay, now we're going to just go quickly through the major trials that studied the mechanical support in cardiogenic shock. So here, the danger shock trial, as we know, is the first trial that showed some mortality benefit in using the Impella CP in patients with cardiogenic shock related to MI. So it's just an open-labeled randomized trial that conducted across 3 countries, conducted from 2013 to 2023. The inclusion criteria were definition of cardiogenic shock by systolic blood pressure less than 100, or the need for vasopressors, elevated arterial lactate of 2.5 or more, and EF of 45%. They have excluded any comatose patient after cardiac arrest, and excluded also the isolated RV failure. Here is their primary outcome. So as you can see here, the 180 days mortality outcome was better on the Impella group compared to the standard group. And this is as well true for the secondary composite outcome in Impella group compared to the standard group. There's certain major safety in this trial, which is basically the Impella group who have shown mortality have a higher risk or higher event of complication. These complications include severe bleeding, lumbar ischemia, hemolysis, device failure, or worsening aortic failure. It's a high percentage when you compare to standard group, so 24% in the Impella group compared to 6.2 in the standard group, which is a big difference and percentage of patient. Here is the major critiques of danger shock trial, and the reason why I'm this is just because it's the first trial that showed mortality on the mechanical support. So one of the major limitation is their strict inclusion criteria, which excluded any patient with cardiac arrest, and STEMI patient, or RV failure, cardiogenic shock. They also has limited generalizability, in which they're done only in 3 countries. And of course, it'll open label. And the other thing is they have a longer enrollment period over 10 years from 2013 to 2023. And the most important thing, outcome also, is the higher rate of complication in MPELA CP group. Okay, this is just another study that was trying to apply the criteria for danger shock trial in CICU patients who were admitted with cardiogenic shock. And as you can see, it's included like more than 20,000 patients in multiple centers across the US. And when they have applied these criteria, they were able, only based on the danger shock trial, to include 4,800 out of these 20,000 patients. And the message here is again, it is limited generalizability, and we cannot generalize it to all patients of cardiogenic shock. Okay, this is another trial that was released in the ACC 2025, the ALT-SHOCK 2 trial. It's basically studied the effect of the balloon pump in heart failure-related cardiogenic shock. And their inclusion criteria, or the definition of their cardiogenic shock, was those patients with systolic blood pressure less than 90 or need for vasopressors, the evidence of hypoperfusion of lactate of 2 or more, or urine output less than 30, and in addition to having reduced cardiac index and elevated pressures. And of course, they have excluded all patients with ACS-related cardiogenic shock and other causes of cardiogenic shock other than heart failure-related cardiogenic shock. Here's the main here's the illustration just showing you the main results. So among those patients, it's included like 101 patients. So 70 or 57 patients there were at stage C of SCAI stage, and 15% they were at stage D, and 28% were at stage B. So as you can see here, the primary outcome measures, which included the survival or mortality benefit and the successful bridge to LVAD or heart transplant, were almost the same between the group. And you can see that the blue or the orange line, which represents the aortic balloon pump and cardiogenic shock, in addition to the standard care, have demonstrated no effect or no major difference when compared to the standard group. Aortic balloon pump shock 2 trial is another trial that studied the effect of the aortic balloon pump. However, it's in AMI-related cardiogenic shock this time. And it's a large trial that included 600 patients, randomized the patient versus for pump plus standard care versus standard care alone. Again, the primary outcome was 30-day mortality. And as you can see this figure, no mortality benefit has been shown with intra-aortic balloon pump at 30 days, and almost like both lines were overlapping in both groups. And here's the same study, but just like a follow-up, 6-year follow-ups. It show basically is at 6 years follow-up, there was no survival benefit or reduction in adverse cardiovascular event with use of balloon pump. ACLS shock trial is another trial that studied the effect of ECMO in patients with AMI-related cardiogenic shock. It included 417 patients where they randomized the patient to early ECMO plus the standard care versus the standard care alone. Again, the primary outcome was the 30 days mortality. And as you can see in this figure, again, no clear mortality benefit was noticed between these two groups. The other things that was noticed are safety outcomes, which included higher bleeding, more vascular complication were noted in the ECMO group compared to the standard group. Okay, before we move to the next and the last part, here is the takeaway message from mechanical circulatory support. So the routine early temporary mechanical circulatory support does not guarantee survival. Danger shock trial is the first trial that showed some mortality benefit. However, it has a limited generalizability with a strict selection criteria, which excluded most of the real world patient. And again, in the same trial, the survival benefit came at the cost of higher adverse event, including bleeding, limb ischemia, hemolysis, as well as renal failure. The balloon pump shock trials, ALT-SHOCK 2 and ACLS shock trials showed no mortality benefit with the routine use of balloon pump or ECMO. And the recommendation from the ACC writing committee is the mechanical circulatory support should be reserved for selected patient with persistent hypoperfusion, despite the pharmacological therapy guided by the shock team approach. Okay, now we're going to move to the last part of the talk, which is the mechanical ventilation and hemodynamics.
Abdul, just mindful of the time, maybe you could...
yeah, I'm just going to, I'll just go through a few slides and then I'm going to stop there. So just this figure show you the basic physiology of the change in pressure at resting state, as we know. So the resting pressures of pleural pressure is negative, and once you take a deep breath, as we know, the intrapleural pressures decreases, which result in decreases the pressure gradient between the venous or between the peripheral circulation and the RP, which ultimately lead to increase the venous return to the RV. And at the same time, with the more negative pressures, the alpha pressures decreases and become low relative to the systemic circulation or the systemic blood pressures, which resulted in decrease or increase in alpha afterload. That's a normal physiology. Positive pressure ventilation increases the pleural pressures, which resulted in decreased right-sided venous return and preload, and as well as increases the pulmonary vascular resistance, which will result in increased RV afterload. And the opposite side, for the alpha afterload, it will result in decreased alpha afterload. And that's because of the parareceptor response from the initial increase in aortic pressures. I'm going to just stop this. So here's what I'm going to say from the application of positive pressure ventilation and the cardiac patient. So few message here. So in alpha failure and pulmonary edema related to cardiogenic shock, if it's left-sided, then using a moderate to high beep will help to decrease the alpha load, unload the alpha, improve oxygenation and myocardial perfusion. But you got to be careful if there is excessive lead, which may lead to lower the cardiac output if the preload is too low. The RV failure using a positive pressure ventilation, as we know, can worsen the RV hemodynamics, decreasing the preload, increasing the afterload, and the recommendation: avoid intubation and positive pressure ventilation in case of RV failure as possible. If you decided to go with ventilation, then be sure to optimize the volume status, blood pressure before intubation, use suppressors and pulmonary vasodilator when needed, and try to pick up the anesthetic agent with minimal hemodynamic effect. And I'm just going to conclude here just for the sake of the time, and I'll open the for any comment or questions. Thank you.